I'm Dr. Jordan White, and I serve as one of the consultant medical directors for the Rhode Island Department of Health Division of Community Health and Equity. Today's lung cancer screening roundtable, the future of lung cancer screening for all communities in Rhode Island, is jointly provided by the Warren Alpert Medical School of Brown University and the Rhode Island Department of Health Comprehensive Cancer Control Program, in partnership with the American Lung Cancer Screening Initiative, the Partnership to Reduce Cancer in Rhode Island, the American Lung Association, the American Cancer Society, and Lifespan. Lung cancer is the #1 cause of cancer-related death in the United States for all people. This is due in large part to the proportion of patients who are diagnosed at a later stage when their options for treatment are limited and their prognosis is poor. The 5-year survival rate for lung cancer patients depends on a number of factors. However, none are more significant than stage at diagnosis. Survival rates are much better for people who are diagnosed with earlier stages of disease. An estimated 47% of all lung cancer diagnoses in Rhode Island occur later, when the 5-year survival rate is only 6%. The United States Preventive Services Task Force recommends annual screening for lung cancer among high-risk patients, and it's now common for health insurers to cover screenings for eligible patients through the use of low-dose computed tomography. However, despite this recommendation and the fast and non-invasive nature of screening, less than 10.5% of Rhode Island patients at high risk for lung cancer have been screened. It's also important to note that due to recent changes in the USPSTF eligibility guidelines, more patients are now eligible to be screened for lung cancer. While that's encouraging news, this larger pool of eligible patients means that this percentage of Rhode Island individuals at high risk for lung cancer who have been screened may become even lower. Today, we're here to raise awareness about how important early identification and screening is for patients at high risk for lung cancer. These important conversations will also give us a closer look at new steps we can take in our daily practices to help connect more patients to treatment and care much earlier. Today, we'll hear from a panel of experts from many different backgrounds about how we can all help to increase screening rates among eligible patients. Together, we'll learn about reducing barriers for both patients and providers, integrating tools into our practice to help identify eligible patients, and providing free and low-cost services and resources to help patients quit smoking safely and effectively to reduce their risk of lung cancer. But first, we would like to recognize and thank our wonderful moderators, presenters, and panel of experts who have graciously agreed to participate in tonight's event, as well as our many colleagues joining us for these important discussions. It is my pleasure to introduce our first presenters. Angela Joe, the lead outreach coordinator for the American Lung Cancer Screening Initiative, and Dr. Karen Teely, who serves as Director of Thoracic Radiology at Rhode Island Hospital. Together, they will provide an overview of the state of lung cancer and lung cancer screening, both nationally and here in Rhode Island. Thank you very much.
Good afternoon, everyone. Thank you for taking the time to attend this webinar on lung cancer screening. My name is Angela Joe, and I'm the lead outreach coordinator for the American Lung Cancer Screening Initiative. Today, we are partnering with the Rhode Island Department of Health to bring you this webinar and roundtable discussion on lung cancer screening in Rhode Island. Specifically, we'll be talking about where we are, the current status of lung cancer screening in Rhode Island, and where we need to be. So a little bit of background about ALSI in case you have not heard of our organization yet. So previous and ongoing efforts from ALSI include organizing webinars for local communities, as well as collaborating with state health departments, hosting a distinguished lecture series with guest speakers whose research have had profound effects on the development of the current USPSTF lung cancer screening guidelines, which we will be going through in today's presentation. We also worked with the House of Representatives last year to pass a House resolution, and this was declaring November as National Lung Cancer Awareness Month. And we are currently working towards passing proclamations in all 50 states in support of lung cancer screening. So why are we choosing to focus on lung cancer and lung cancer screening specifically? This is because lung cancer is the most fatal and the third most common cancer in the United States. Every year, the American Cancer Society estimates the rate and number of new cancer cases and cancer deaths in the US. These here are the 4 cancers, excluding skin cancer, with the highest estimated number of new cases in 2021. Lung cancer is estimated to cause around 235,760 new cases in just this year alone. According to the National Cancer Institute and the ACS, 6% of all people, which roughly translates to 1 in 15 men and 1 in 17 women in the US, will develop lung cancer within their lifetime. The current US population is around 330 million people. This means that roughly 19.8 million Americans will likely develop lung cancer within their lifetimes. Here are the 2021 estimated deaths from the same 4 cancers as shown previously. As you can see, lung cancer is the leading cause of cancer death in America by far, and this trend has been observed for multiple decades. More specifically, lung cancer has been the leading cause of cancer death in men since the 1950s, and it surpassed breast cancer as the leading cause of cancer death in women in 1987. So the data I've shown so far is at the national level. Looking at the 2021 statistics in the state of Rhode Island specifically, the ACS estimates that 950 new cancer cases and 430 cancer cases in Rhode Island will be caused by lung cancer. And here are just two maps to visualize the distribution of lung cancer incidence rates, which is the map on the left, and mortality rates, which is on the right, in Rhode Island between the years of 2013 and 2017. So both new lung cancer cases and cancer deaths are most prevalent in Kent County. So some of you might be wondering why the mortality rate is so high for lung cancer. And this is typically because diagnosis of lung cancer doesn't occur or is not found until the later stages. This chart shows the correlation between 5-year survival and stage at diagnosis, as well as the percentage of lung cancer patients that currently fall within each category. Each color represents a different stage of diagnosis and its corresponding 5-year survival, with blue being early with a more positive prognosis, pink being regional, corresponding to a less positive prognosis, and green being distant and correlating to a poor prognosis. This is key because despite the data showing that diagnosis at an earlier stage can lead to better chances of survival, still almost half of all lung cancer cases diagnosed between 2010 and 2016 were categorized at the distant stage. One likely contributing factor to the high mortality rate is the tendency of lung cancer symptoms to appear at the later stages. These symptoms include chronic cough, coughing up blood, chest pain, hoarseness, loss of appetite, fatigue, unexplained weight loss, persistent lower respiratory infections such as bronchitis or pneumonia, new onset of wheezing, and shortness of breath. Additionally, clinical data and research have shown that there are significant racial disparities in lung cancer. African American males have the highest age-adjusted lung cancer incidence rate among all racial groups at around 73.5 per 100,000 individuals, and they also have the highest lung cancer mortality rate at around 62.1 per 100,000 individuals. For African American individuals who smoke, lung cancer develops at an earlier age, and patients are more likely to present with advanced stage disease, and that is compared to white or Caucasian patients who smoke. Additionally, studies have shown that African Americans have slower nicotine metabolism and clearance, and they smoke at higher intensities. And this results in greater exposure to tobacco carcinogens at lower amounts of cigarette consumption, again, compared to white and Hispanic smokers. Furthermore, African Americans were less likely to be eligible for lung cancer screening compared to white smokers under the 2013 USPSTF guidelines, which is one of the key drivers behind the 2021 updated guidelines that we'll be going through in a few moments. So in the next section of this presentation, Dr. Terrence Healy, who is one of our panelists, will briefly discuss the key information to know about lung cancer screening. But before we move on, here are the key takeaways from the info that has been presented so far. So lung cancer is very common, and nearly 230,000 people will be diagnosed or are estimated to be diagnosed with lung cancer in the United States this year. Lung cancer is very deadly and is the #1 cause of cancer-related death in the United States, and the majority of patients diagnosed with lung cancer are diagnosed at a later stage when the treatment options are unfortunately few and the prognosis is relatively poor. So now we'll be moving on to discuss the second half of today's presentation, and that would be lung cancer screening.
I'd like to thank the panel for having me. My name is Terrence Healy. I'm a thoracic radiologist, and we're going to talk about lung cancer screening today. The idea of lung cancer screening is nothing new. There have been lots of trials throughout the world looking at screening for lung cancer using a variety of methods, but we're going to focus on CT scanning for lung cancer in this portion of the talk. This is a very important paper, the National Lung Cancer Screening Trial. What it did is it randomized patients into annual CAT scans for 3 consecutive years or annual chest radiographs. And this study, some people, epidemiologists, think that this is one of the best designed studies the US government has ever funded. All the available parties were involved: epidemiologists, public health officials, physicians, pulmonologists, intensivists, radiologists, you name it. They were at the table designing this trial. And it was designed to be stopped when the CT arm of the trial identified a 20% decrease in mortality. So we look at all the patients who got chest x-rays, you follow them, and you see who gets lung cancer. Similarly, we follow the patients that got CAT scans, And of all the patients that got CAT scans, there were 20% less lung cancer deaths in that group, and this study was stopped prematurely. The proportions of lung cancer diagnosed in each stage specific to the National Lung Cancer Screening Trial is very important because in the low-dose CT arm, of those cancers that got diagnosed in patients that had the CAT scan, over half of them had this early stage lung cancer, this stage 1 and the stage 2. These can all be successfully cured for the most part with surgical resection, certain types of radiation therapy, and local ablative therapies. As you can see in the patients with the chest radiograph group, there were fewer patients identified in this early stage, and more of the patients were identified in this late, untreatable and uncurable stage of lung cancer. So this is a very important result and did exactly what we've been trying to do, is identify lung cancers at an early, treatable, or even curable stage. Now, some of the criticisms of the National Lung Cancer Screening Trial were that there were too many false positives, and that is a valid criticism. Some of the earlier trials identify these little dots or nodules in the lung in as high as 60% of patients. That's a lot. So when the National Lung Cancer Screening Trial was published, a group of experts reviewed the data and said, how can we make the number of false positives less? Well, one of the main things that we found was we traditionally used a size threshold of 4 millimeters to consider a nodule worthy of follow-up or a positive requiring additional CAT scanning, biopsies, PET CT scans, or even surgery. After the National Lung Cancer Screening Trial, there was a committee whose goal was to develop the recommendations for positive screens, and it was decided that we would only call patients back sooner than an additional 1-year follow-up if the nodules, rather than being 4 millimeters, were 6 millimeters. So those 5 millimeter nodules and 4 millimeter nodules, rather than coming back for another CAT scan in 3 months, we'd wait a full year. The nodules do require growth for pre-existing nodules that grow will require further workup. And it was determined that if you use these new lung RADS recommendations, eliminating those 4 and 5 millimeter nodules, which are extremely common, will substantially reduce the false positive result rate by almost 70%, with smaller corresponding reductions in sensitivity. So we're still finding meaningful cancers by not spending as many resources on these tiny 4 to 5 millimeter nodules. This is a trial, a similar trial, the Nelson trial, which basically identified the same trends as in the National Lung Cancer Screening Trial in the United States, whereas again, almost half of the lung cancers that were diagnosed with CAT scan were early stage and potentially curable and certainly treatable, as compared to no screening. So these patients didn't even get chest radiographs. You can see with no screening, we're really finding lung cancer at a very late stage. Patients are symptomatic without significant treatment options or options for long-term survival. Now, don't worry about the details of this, but on the Nelson trial, the idea with screening is you want to find the lung cancer early. So in the screening population, you're finding lung cancer at a higher rate than doing nothing, and you're doing this within the first year or so. If you look at the lung cancer mortality, or the patients who die of their lung cancer, you can see this blue curve is the group that got the CAT scans. These patients are not dying at as high of a rate as those patients who are not being screened at all. And it's this difference that's clinically significant in that the screening group is seeing a survival benefit over the control group, similar to the National Lung Cancer Screening Trial in the United States. Now, these are brand new recommendations from the United States Preventative Services Task Force regarding lung cancer screening. The ages have been extended to age 50 to 80, and the number of pack years, rather than being 30 pack year smoking history, has been reduced to a 20 pack year smoking history. And as I alluded to earlier when we were talking about African-American patients, this is quite important because, as I said, the African-American population tends to get lung cancer with less number of cigarettes smoked as compared to Caucasian patients who get lung cancer. Number 3 say the same. The patients who are going to be screened have to be current smokers, or if they are former smokers, they had to have quit within the last 15 years. Actually, this seems like a simple experiment or calculation to determine the patient's pack years, or number of packs of cigarettes smoked a day. You multiply that by the number of years and you come up with a number. And the number that we're looking for, we used to use 30, but like I said, we use 20 now. So it's 1 pack a day for 20 years, for 20 pack years, or 2 packs a day for 10 years, or 20 pack years. Now, having been doing this since 2015 on a large scale, I'll tell you that this calculation is not as simple as this example on this slide is. Patients don't always smoke the same number of packs of cigarettes a day for 10, 20, 30 years. They may take breaks. There is recall change. The patients may tell their doctor that they have been smoking 20 or 30 pack years, but on my questionnaire, when they come to get their CAT scan, they may give me a completely different number. In fact, some patients that we've been screening for 5 or 6 years now, each year they come in and we ask their smoking history, it's a little bit different. So I'm not sure actually how reliable or reproducible this calculation is in everyday clinical practice. These are some lung cancer screening rates in Rhode Island. You can see in 2019, we did pretty good in colon, cervical, and breast, up to 89% of patients being screened for cervical cancer. Lung, in 2018, 10.5% is calculated. I'll tell you, nationally, some people are reporting less than 5% of the eligible patients for lung cancer screening actually getting this CT for low-dose screening. So we have a long way to go here, and that's one of the main points of having this webinar today is to try to spread the word. The cancer incidence and mortality rates, you can see the highest mortality, again, from lung and bronchus as compared to breast, pancreas, and colon. And then the second most cancer type, again, Rhode Island cases, 950. I think we showed this a little bit earlier, but the take-home message, very important message is lung and bronchus, most deadly of all cancers. There are many barriers to lung cancer screening. There's a lack of awareness, and that awareness, goes from the providers to the patients, to the family members, and to the general society. Managing abnormal results. This is a huge problem, especially I hear from my family practice colleagues. It's so difficult to manage all of the incidental findings that are generated by lung cancer screening, which could include an adrenal lesion, which needs follow-up, or a kidney lesion, or a liver lesion, or a mediastinal lymph node, or a thyroid nodule. These things are very difficult to keep track of, and they have huge medical legal implications. Identifying eligible patients, this is also difficult. Like I said, it's very difficult to get an accurate pack year smoking history. Conducting shared decision-making, which is an important part of lung cancer screening, is very difficult to add more time to a primary care physician's or a nurse practitioner, any primary care provider's visit. You're already asked to do so much. Conducting the shared decision-making or asking the patient, if you undergo the screening, are you going to want to undergo a PET CT scan or a biopsy? We may find things that need additional follow-up. Is this something that you would be interested in doing? There are unfortunately challenges to access the CT scan. This is something that I've been working on extensively in our outpatient practices. Patients have trouble with transportation. Patients have trouble with being undercovered. Patients have trouble getting into the office for fears of their immigration status. These are all things that I've come across in the past 5 years. Hopefully now with the U.S. Preventative Task Force's recommendation, the concerns over cost should be limited, especially for our Medicare and Medicaid population, who this is definitely covered. For third-party payers, this is also a covered service if you have private insurance. There's a lot of stigma, and we're going to get into this in the panel discussion, about being screened for lung cancer, having smoked a significant amount of cigarettes in your life. Patients, family members, clinicians are generally unfamiliar with the guidelines for screening and follow-up guidelines. There remains skepticism regarding the evidence of lung cancer screening, all things that we're trying to overcome. Patients have many concerns about CT for lung cancer screening. The most common thing I hear about is, oh, this CAT scan has radiation. Is the CAT scan going to give me cancer? And we know from lots of research in the past that there is a normal amount of background radiation, including radon, ingestion, inhalation. All of this radiation, which we cannot avoid, certainly outweighs the amount of radiation that you will be getting from a low-dose CT scan. And we know the patient population that's getting scanned, these 50 to 80-year-old patients, the effective medical radiation is extremely low. We worry a lot more about radiation exposure in younger patients and pediatric patients. As you can see here, Medicaid coverage, Rhode Island was actually a purple state until a couple years ago. And it was very embarrassing. I was at a national meeting and this same slide was put up. And here I was being the national expert on the radiology of lung cancer screening, and my state was not covered. Just a side story. I really like to thank our local leaders in Medicaid, because I made one phone call, left a message about the concerns of Rhode Island being a not covered state. And literally within a week, I heard from the Rhode Island Medicaid administrator, and Rhode Island is now a blue state. So Medicaid fee-for-service coverage does exist in Rhode Island, and hopefully all of these states will change to blue by the end of this year. Smoking cessation. This is extremely important. Lung cancer screening is not an alternative to smoking cessation. In fact, smoking cessation counseling is required by Medicare and some Medicaid services for a lung cancer screening program. Urging our patients to stop smoking is very important because patients who stop smoking for 5 years decrease their risk of lung cancer by 39.1%. We have lots of good options in Rhode Island for lung cancer, for smoking cessation, which we will also get to during our panel discussion.
So now understanding the important role of lung cancer screening in catching the cancer in the early stages, what are the standards for best practice to work towards getting more eligible patients the screening that they need? So we have to actively address both patient and physician barriers to lung cancer screening, which were covered previously, and for treatment. Accurately identify individuals who are eligible under the new 2021 USPSTF guidelines, as well as provide access to screening at qualified facilities for these eligible individuals. We also have to ensure appropriate follow-up for both positive and negative screening results. We need to promote continuous quality improvement of screening programs and downstream care. We also need to provide smoking cessation support for all individuals who smoke. And lastly, close the gap between lung cancer screening and other recommended cancer screenings. So that is all for our presentation portion of today's event. Thank you for your time and attention, and we look forward to any questions you may have during our roundtable discussion, which is coming up next.
Hello and good afternoon, everyone. I want to first say thank you to Dr. White for the warm welcome today. And thank you to Angela and Dr. Healy for those really informative presentations. My name is Dan Fitzgerald. I work for the American Lung Association as our National Senior Manager of Advocacy and our advocacy lead here in the state of Rhode Island. I'm really honored to be serving as the moderator for our panel discussion today. And I'm especially excited to be joined by our esteemed lineup of panelists for this discussion. So with that said, I will jump right in and start introducing our panelists. I am pleased to welcome Julia Doherty. Julia is the Nicotine, Substance Use, and Addiction Treatment Coordinator for the Rhode Island Tobacco Control Program at the Department of Health. She currently oversees the state nicotine helpline, or 1-800-QUIT-NOW, and is supporting efforts to integrate behavioral health services and nicotine dependence treatment throughout our state. As both a public health professional and as a licensed clinical social worker, she's passionate about whole person care and is committed to improving the quality of life and access to services for underserved populations. Welcome, Julia. Next, I'm pleased to welcome a friend who we've already met today, Terrence Healy, who we just heard in one of those great presentations. Dr. Healy graduated from the combined Dartmouth College and Brown University program in medicine and completed his residency in diagnostic radiology at Rhode Island Hospital and the Warren Alpert Medical School of Brown University. He went on to complete a fellowship in thoracic radiology at Massachusetts General Hospital. Dr. Healy is certified by the American Board of Radiology and is the Director of Thoracic Radiology at Rhode Island Hospital. Welcome, Dr. Healy. Next, I am pleased to welcome Ross Hilliard. Dr. Hilliard is a general internist practicing at Rhode Island Hospital and the Rhode Island Free Clinic. His work in informatics includes roles as the Director of Medical Informatics for Lifespan Health System and as the Senior Health Information Systems Advisor for Brown Medicine. He also currently serves as an Associate Residency Director for the Brown University Internal Medicine Program. As Director of Medical Informatics, he works with a team to improve the hospital system's EPIC EMR so that it can better serve patients, physicians, and allied health professionals. These efforts center on improving patient safety and guiding teams to deliver high-quality care to patients. Welcome, Dr. Hilliard. And next, I'm pleased to welcome Kristen Hubbard. Dr. Hubbard is a primary care physician with Coastal Medical Lifespan. She joined the East Greenwich practice after completing residency in 2015 and has been involved in population health management while at Coastal. Welcome, Dr. Hubbard. Thanks for being here with us. And finally, last but certainly not least, warm welcome to Linda Nietzsche. Under Dr. Nietzsche's leadership, the Providence VA Medical Center began a lung cancer screening program in 2013, which has been highly successful in identifying early stage lung cancer in the veteran population, with several peer-reviewed publications, as well as a citation of excellence from regional VHA leadership. Dr. Nietzsche is the Chief of Pulmonary and Critical Care Section at the Providence Veterans Administration Medical Center and Professor of Medicine at Brown University. She transitioned to the Providence VAMC in 2004, where her focus has been on clinical work and clinical research in COPD and pulmonary rehabilitation. Welcome, Dr. Nietzsche. And welcome to all of our wonderful panelists. I'm really excited to be here today. And we have some really big questions. I think our hour is going to go quickly. And with that said, we also have a really diverse group of participants with us today from all over and from many different backgrounds. So, for our discussion, I hope we can expand upon the incredible presentations that we just watched and dive deeper into guidance around overcoming patient and provider barriers to screening, discuss cessation resource availability and how that connects to this conversation. And I would love to spend some time hearing about best practices and kind of the next steps to move this work forward. So with that said, I will toss our first question actually over to Dr. Hubbard. Dr. Hubbard, if you could briefly describe some of the patient barriers to screening that are most often seen in primary care settings. So over to you.
Yeah, sure. Hi, everybody. So as a primary care physician, I think once we identify patients that are eligible for screening, we do face some barriers with going through with the lung cancer screening. So I would say one of the biggest ones is actually having the patients themselves agree to this type of screening. I think when we talk about lung cancer screening, a lot of times patients feel really either embarrassed or guilty about their smoking history, knowing they're increasing their risk of cancer. So we hear from them, well, I did this to myself, so whatever happens, happens. I wouldn't want to know anyway. And so it gets a little bit challenging to sort of counsel them and talk them through why we're doing this and how we can improve their outcomes and that type of thing. I think unlike other types of screening, this is something where patients feel we're looking for a diagnosis of cancer that might be self-inflicted. And that being said, a lot of times they don't want to know, just as simple as that. They feel like had they made different choices, maybe they wouldn't be, talking about lung cancer screening. So I find that to be one of the biggest challenges with my patients. Other barriers, I would say, cost. I know it's covered for the most part, but I think patients are always worried about cost. Do I have a copay? Is this something I need to pay for? And actually transportation. So we do have, a fair amount of patients who rely on family members or ride services to come bring them to the office. So, adding another test, at another point in time, kind of falls to the bottom of their priority list when they have to ask for rides or set them up. So those, I think, would be the biggest barriers as far as the primary care setting.
Yeah, that's really helpful. And I think, we heard a little bit in Dr. Healy's presentation and in the beginning of your answer as well, Dr. Hubbard, about stigma. And there's, still today a lot of stigma in the lung cancer conversation in general. So I'll throw it over to Dr. Nietzsche, if you don't mind. I'm interested in your perspective on some common examples about how stigma presents in clinical settings and maybe how that stigma can actually impact accurate identification of patients who may be eligible for lung cancer screening.
Thank you. Yeah, and I think I have to agree with Dr. Hubbard. The biggest thing we see is that embarrassment about smoking. So identifying eligibility really depends on a good pack-year smoking history. And even Dr. Healy touched on how tough that is to begin with because it's not a linear equation. But they also are sometimes embarrassed to tell you that they've tried to quit 3 or 4 times and they're still smoking and their wife's been on their back or their kids have been on their back and they can't stop smoking. So I think the smoking issue is probably the biggest one that impacts. I think the other thing is I don't think people understand that lung cancer isn't always a death sentence. So I think that, the common understanding, which has been true up until recently, that most cancers are diagnosed late and they are a death sentence. So to try to sort of twist that understanding around and say, well, that's precisely why we want to do the screening. We want to identify these early cancers, and even in some cases, some of the later stage cancers, given molecular markers, are actually having really good responses. So I think there needs to be some couched optimism when you're talking about making that diagnosis of lung cancer. And again, when people fear, they just don't freely disclose important information or lend themselves to getting that necessary information for eligibility. In the veteran population, also what we see is a lot of they are nihilistic in some way. I mean, a lot of these veterans have been through a lot. And so a lot of them will say things like, why bother? And it's why bother from smoking? Why bother to make a diagnosis? Why bother to treat? So I think it is a lot of how we approach these patients with a bit of an optimistic or at least view that we can actually do something about this.
I love that answer, and I love the phrase of the couched optimism. I think that's really helpful, even just to frame our conversation. And I think I'll toss it over to Dr. Hilliard to maybe build off of that. And kind of we've been talking about stigma, but maybe from your perspective, what other practices can be implemented to help reduce stigma as a barrier to patient, as we've been talking about, and could things like a motivational interviewing approach be effective in a short visit to help accomplish that? Any thoughts?
So I think absolutely motivational interviewing can be beneficial. I kind of normalizing it, just as we attempt to do screening for other things that patients may have kind of reticence to share with us in a primary care setting. Kind of just normalizing it. I ask this of everybody. Other things can be in kind of standardizing this intake. of having somebody else who just kind of asks, like, hey, we ask everybody as we try to go. Certainly, it is very complicated to get a very accurate pack year history, but to get a general idea, if your pack year history is 30 plus now and is consistently 30 plus, that's all we need to move forward. I think too, some of it, as was touched on in the presentation before, it is, for Kristen and myself, there's a lot to be packed into a regular preventive visit. And in many cases, both the pressing needs of the patient or the pressing concerns of the patient may kind of outweigh getting through every single other screening element. So I think there's some need to have this be something that's a little more automatic, a little more prompting, because at the end of a 15 or a 20 or a 30-minute visit, if you're lucky enough to have that length of a visit, some things can't always fit into those. And with patients who already have barriers to access to care and time in there. We're trying to cram a lot in.
For sure. And I think I saw Dr. Hubbard unmute. Do you have anything to add there?
Yeah, no, just agreeing with that 100%. We definitely have those time constraints. And I think patients having a more education about lung cancer screening would be helpful, because it's really easy to say we need to update breast cancer screening and colon cancer screening, but as soon as you say lung cancer screening, well, what do you mean? And it's very, it's a lot longer conversation because it's not as well known.
Sure. And that's a really great segue over. We've talked a lot about stigma and, the connection of smoking and lung cancer. And so, Julia, I don't know if you could spend a moment sharing some of the programs or resources that are available here in Rhode Island to help educate people who smoke on lung cancer and screening availability. Any thoughts?
Yeah. So you've identified a really great area of growth for the cessation treatment kind of area of expertise, because we do a lot of focusing on how can we help healthcare facilities do referrals to cessation. And there's not a lot of best practices around how can quit lines and cessation help do the pack year screening and referral to education and referral to lung cancer screening. So it's not something that's integrated currently into the national accredited tobacco treatment specialist trainings. And it's not something that's part of our quit line protocol at our state or many other states. So it's definitely an area for increased partnership, because we, for example, there's been a pilot study that's not finished. They're currently assessing it, but having, your quit lines in your intake, do an assessment of pack year history, and then see if they would be eligible and help with a local referral. Or, for example, in their welcome packets, when they give information about, why is cessation important? How maybe is it going to impact your other chronic diseases if you may have one? Also, maybe what is lung cancer screening? What is eligibility, and some education material there. So that's an area the Department of Health is really trying to be thoughtful about our strategic planning across programs. So definitely that's an area for continued kind of partnership with healthcare systems, as well as the cancer control program. So I think it's a great example of why it's good to have cessation on a panel like this. So there's that bi-directional learning.
I couldn't agree more. I think that's the reason, right? Why we're here today, kind of across discipline, across this kind of broad scope of work to talk about the gaps and identify room for improvement. I saw Dr. Nietzsche, you needed anything to add there?
Yeah, I just wanted to add to Julia's comment, it also goes the other way. So the way the VA system works is with a lung cancer screening coordinator. And what we've tried to do is have them partner with the smoking cessation program, so that when patients come in for lung cancer screening, the opposite is true also. We talk about, this is a teachable moment, or at a time where smoking cessation may really hit home. So I think that collaboration is crucially important in both directions.
Couldn't agree. Absolutely. Couldn't agree more. So, to kind of wrap up this kind of first series of questions about patient barriers, I'll toss it over to you, Dr. Healy. In your presentation, you talked a little bit about the recent changes to the United States Preventative Services Task Force guidelines, and you talked even about the mere 10.5% of those eligible who are currently getting screened. So could you expand a little bit upon that for a moment, just thinking about what do those changes mean for patients, and how might those guidelines impact barriers to screening for patients?
Yeah, Dan, thank you. I think unlike breast cancer, prostate cancer, colon cancer, where we sort of know the number of patients who are eligible for such cancer screening, lung cancer, we really don't have any idea exactly how many patients in the US or how many patients in Rhode Island actually qualify for it. We're going to get to this probably a little later, but there are different types of screening programs. I know Dr. Nishi has the benefit of a great VA system and a coordinator. But for us to reach Rhode Island as a whole, all the communities of Rhode Island, we're gonna have to figure out a decentralized screenings program, meaning all of these outpatient imaging centers are gonna have to deal with lung cancer screening in an effective manner. For example, I have 12 outpatient imaging centers scattered throughout Rhode Island. And a recently submitted paper, we found that less than 1% of our screened patients in Rhode Island are African Americans. So we certainly have barriers to certain populations in the state. And I think the number one thing that we can do for patients is education. And I think a lot of that education has to be done from the public health sector, which is why I'm very happy that the Rhode Island Department of Health is actively engaging this process. And I can tell you, unfortunately, the pandemic had a huge negative impact on lung cancer screening last year. I was on pace. I should have done about 5,000 screens in our outpatient office last year. We did less than 3,000. The number is getting back to normal, but Dan, we're really going to have to improve transportation, education, and spread the word that this is a covered service with no copay, which I think is a huge barrier.
Oh, thank you for that. And I think what a perfect summary of a call to action of why it matters that we're having this conversation today, why our, kind of applied public health or medical providers and the important work that you're all doing and the important work that our public health partners are doing, and how there's a lot more that we can all do to help reduce those barriers, reduce that stigma, provide more education, as you all just touched upon. So thank you for all of those really thorough answers. And so now kind of switching gears a little bit, let's talk about overcoming barriers for providers. I know we've heard a little bit about some of those, the barriers to providers so far, but I don't know if Dr. Hubbard, if you want to kick us off by sharing some common barriers for providers to assessing eligibility and screening patients for lung cancer.
Yeah, so I say one of the biggest ones, and I think we've mentioned it a few times now, is that none of our patients, when you ask them about their smoking history, says I have a 32.4 pack year history of smoking. So again, getting an accurate history, and a lot of times the answer, is, oh, I've been smoking a long time, or well, I've tried to quit a few times here and there. So just kind of walking them through it. How old were you when you started? Are you still smoking? If they quit, how long ago? And on average, how many packs per day? And sort of, it's kind of always an estimate, right? Because it's not always exactly a pack a day. And then just making sure, the other thing is making sure we keep it up to date. So once we have our initial smoking history, every year that will change, keeping it up to date in the medical record, making sure if they did quit, we put that in there. So I think the other sort of barrier to assessing eligibility, and I always worry about this, is missing those people who did quit. Because even as a new provider, I've been at Coastal about 6 years, if I have a patient who, they put former smoker, great, well, good for me, I don't have to counsel them, right? No, but at the same time, they might have stopped smoking 8 years ago, and they do meet the criteria for screening. So we have to stop and talk to them about that kind of thing. How long ago did you quit? And just make sure we're not missing those types of people and just saying, well, former smoker, so we're good to go.
No, that's helpful. And I think, to other points that were made as well, of the need for increased education to our patients as well, just to understand that, while, awesome that, we're able to quit, but understanding that that risk is still there, and that a screening could be, they may be eligible. So for sure.
Exactly.
And, so Dr. Healy, you've already talked a lot about the USPSTF guidelines and what that means for patients. But for just a moment, you want to expand upon that previous answer, just from a provider perspective. What does that change mean for providers?
Yeah, Dan, thanks. I think that's a great question. Some people estimate that the change from 50 to 80-year-old eligibility and going from 30 to 20 pack years could double the eligible population for lung cancer screening. And as I have mentioned, I think the biggest barrier for providers is, as a radiologist, I'm forced to look at everything. I can't just look for lung cancer. So I'm going to find adrenal lesions that are going to need MRIs, that are going to, have to take patients away from their families, and again, transportation. All of these incidental things, not only is it tough for the primary care providers, it's a big medical, during their daily visit, this is a medical legal issue. If I find a kidney lesion and Dr. Hubbard doesn't follow up on it appropriately, or I don't follow it appropriately, I could really have medical legal implications. So providers, I think that's the single most thing is, Dr. Healy finds a nodule in the kidney or an adrenal, liver, and when I don't find it, what do I do? I think the providers don't actually always know the next right step. And I think as radiologists, it's our job to provide scientifically backed follow-up recommendations that are clearly visible in the report. And we have to develop systems to track and close the loop when we find something. Who's actually responsible for following up this kidney lesion, and what do we do about it? Unfortunately, not all radiologists give evidence-backed follow-up recommendations. So what we've done in our practice is anytime we do give a recommendation for follow-up, we put a citation or a guideline. Okay, a renal lesion should be, an MRI should be ordered, and it should be ordered in this way based on this exact paper. So I think we have to be a little better about our recommendations and closing that loop. So from a provider standpoint, I think we all could do a little bit of a better job. Unfortunately, this is very resource intensive.
No, that's really helpful. And I saw Dr. Hubbard, you unmuted. Feel free to jump in.
And just to add on even to that from a patient perspective, so when that does happen, I just think we have to understand now we're going back as PCPs to the patient and saying the lungs look okay, but now we found XYZ and we have to do all these tests. And again, the worry comes back about cost, and it's tough on them too.
For sure. And, I think too, I believe Dr. Hilliard made this point earlier about just in such a short primary care visit, how many things are happening and kind of the need, for some assistance and how we can maximize that time, or reminders for some of this really important, pre-screening measures. So, with that in mind, Dr. Nietzsche, I'm interested, as we heard under your leadership, the VA launched a lung cancer screening program. And I'm interested in your perspective on how something like an electronic health record could be used to improve eligibility assessment and even potentially increase consistency in patient tracking and follow-up. Any thoughts there?
Yeah, I think, I think what's coming out is that these have to be very well coordinated programs with direct lines of communication that are clear. I think Dr. Healy's point is really well taken. If no one's there to pick up all the incidental findings, where do they go? And also, I think the VA has done a really good job of looking at organizational structure based on the electronic health record. So we use this, what's called a hub and spoke kind of mechanism, where you have centralized services that have chest radiologists that are good at reading these things, that adhere to lung rads and then can give those guidelines. But then who takes that on? And while we think the primary care doc is the entry point for patients, and we do depend on clinical reminders in the electronic health record for the primary care provider with their staff to fill out to identify patients, it all can't be left on their shoulders to do everything past that. So we have lung cancer coordinators who do the shared decision making if the primary care doctor can't do that in the time allotted. And those coordinators also will follow up on those incidental findings as well as the lung RADS findings. And in our electronic medical record, any lung RADS reading automatically goes into a database that is continually updated with each study done. So we're able to track all positive lung cancer screenings in a way that we hope things don't fall through the cracks. But even with the electronic medical record, it relies on the pulmonologist being available to work up larger nodules, depends on the primary care provider hearing about the incidental findings, and the lung cancer coordinator sort of keeping track of that database to make sure people move through the queue in an appropriate way. I mean, it's been very successful, and it's granted it is not necessarily transferable to a larger non-closed system, but I think some of the ways things are done with very clear lines of communication have to be adapted to the larger community. And that's especially true for communities that don't get access to care. Because even within the VA system, we have homeless veterans, we have veterans that are not within a good primary care pack, as we call them, these healthcare teams. And we struggle with that. We have to call in social workers to help these guys get to their appointments. And so I think it is a much larger scale outside the VA, but I think there are some lessons to be learned in how we've sort of tried to parse it out that everyone has a job to do and everyone's job is important.
That's really helpful. And I'm even just thinking, you mentioned, in a non-closed system, an EHR may have some limitations, and how there's a lot of people at play and a lot of different roles and responsibilities to try to ensure continuity of care. So maybe to build off of that, Dr. Hilliard, like in the absence of some of the functionality of an EHR, how might we bridge the gaps of, and sometimes that could be using existing or new support staffs. Any thoughts there?
So I think it's a great question. I think Dr. Nietzsche brings up, the benefit of a really connected system in the fact that the electronic system can help support this. One benefit that I don't know everybody is taking it full advantage of and would require some rework and people to do some of the screening. One of the requirements of any EHR in the country is that it's able to capture tobacco use history. So we have the ability in every EHR in the country, and at this point, virtually every primary care setting is going to have an EHR. Those EHRs have the ability to capture it. Now, as Dr. Hubbard mentioned, and as I've seen plenty of times, it just becomes a former smoker and nobody takes the time to actually, record what the PAC history, PAC year history was. And so one step is a structured way of doing that. And that probably can't and really shouldn't fall to the primary care physician, but an additional support staff as part of that screening. I think as Julia talked about in, collaborations with cessation counseling and cessation counselors and cessation groups would be ideal for that if we can have that. But a lot of it, will require us to bridge these systems that are currently still very siloed. And so, like Dr. Healy said, having clear recommendations, both in terms of time of follow-up and references for why, are helpful. I think some of the things that have been done in some of our groups in Rhode Island with, kind of levels of importance that are included very clearly on the report, as well as a timed follow-up, those can then be translated to reminders in other EHRs. That's going to require someone entering it manually, but could be done with some coordination and with some training. You could train support staff to say, okay, this result, came back and the lung cancer screening is good for the next year, but the, adrenal incidentaloma needs to be followed up in, 6 months, and we have to do this other study for this. How does that go? And so with some coordination, it would be possible to kind of direct that, but I think that means that the radiologist needs to be very clear in here are the next steps that need to happen. And then there need to be clear steps and support for the folks receiving that to actually plug that in the absence of a fully connected system like the VA is able to offer.
That's really helpful. And I think even just from kind of what I'm hearing, really lots of really awesome opportunities, but it comes down to the coordination and the communication to help actualize those and maximize that for impact from a provider perspective and on the patient side there. So, and that kind of makes me think too, like connecting back to some of our earlier conversations about resources. Julia, maybe you could share maybe what resources exist in Rhode Island that could help providers overcome some of the barriers we've talked about related to cessation, and how might those resources be integrated into a provider practice? Any thoughts?
Yeah. So just one thing to think about, because we're talking about the difficulty of sometimes having those conversations with smokers about if they're comfortable talking about their readiness to quit. So research does show that about 7 out of 10 people who smoke would like to quit. However, it is a journey. Like the average is about 7 quit attempts, and so that's a long journey for folks. And so I think Dr. Nietzsche spoke a little bit too, for some folks, the feeling of shame or dissatisfaction with not having successful quit attempts. And so part of that is, although many smokers a year attempt quitting, only or less than 1/3 really use the best practices to help support in cessation. So that looks like cessation medications, so nicotine replacement therapy, or in-person or telephonic counseling. And so it really is important to your question to think about the ways that we can integrate more of these supportive best practices to really help patients in their quit journeys. So Tobacco Free Rhode Island is a great organization, and they have a wonderful website that captures in just one simple one-pager all of the cessation services that are offered in the state, both in person and online. So Kodak Behavioral Health, for example, has tobacco cessation services, both group and individual, as well as Thunder Mist. And then there are many kind of online quit resource options as well. But one thing that I really want to focus in on is the state quit line, because that's something that we can really talk about integrating into provider practices in a supportive way, and also because it's free. So that access piece that we were talking about is really important. So patients can self-refer. They could just call the quit line, 1-800-QUIT-NOW directly. But also there can be referrals from doctors. And so what you get with that quit line is 4 weeks of NRT free and 5 counseling calls from certified counselors that use MI and CBT techniques. And there's pregnancy, postpartum, behavioral health, and chronic disease protocols that kind of expand those services and help focus in on specific needs. And if a provider refers to the quit line, so if we have a HIPAA covered provider referring to the quit line, what happens is the patient then gets a direct call and multiple follow-ups, so they don't have to kind of muster up the courage to call and feel confident in reaching out. And additionally, providers can then get feedback from the quit line if their patient was reachable, if they have successfully quit, if they're thinking that maybe Chantix or another prescription NRT is a better option for them, and they need to kind of be referred back to their medical provider. Currently, the way referrals can be done is through fax or web referral, which we know is a barrier. That's not the quickest, most integrated, easy way to do that, and that takes time. Something that many other states have done as a best practice, and Rhode Island is really exploring, is EHR integration. And actually, our tobacco control program currently has some funds to provide to pay for the integration into EHRs. So what that can look like is very quick referrals. And we can talk about thinking about how rooming staff, for example, can support in doing that and make it a little easier for the time limitedness of these our primary care visits. And then lastly, I would just say that we've also provide we provided kind of like workforce development through paid academic detailing, and we can still do that. So if providers are interested in kind of one-on-one counseling about some of the techniques that, for example, Dr. Nietzsche's staff sounds amazing at, kind of that couch optimism, that the MI work. So talking about that, as well as integration. So what do the workflows look like, and where can maybe points of integration be? So we have both patient-facing and provider-facing education materials. And we paid for tobacco cessation specialist training to kind of expand the workforce and expertise there as well.
Thank you so much for the thorough walkthrough, because I think it's so helpful. A lot of my career has been in the nicotine dependence space, and oftentimes it can feel like some of our worlds are kind of siloed. So I think, to your point of really integrating that work together is the key of how we can really move that forward, and finding spots like you mentioned, the Tobacco Free Rhode Island website, where you can house all of these great resources throughout the state, getting to the points of some of those barriers we talked about of, accessing these, the cost, the transportation, and finding different things that work for different people. And I think that's kind of a perfect segue into kind of the next bucket of our conversation, hopefully around best practices and follow up and next step, and something like your suggestion there, Julia, about integrating the quit line into EHR sounds like such a great way to help reduce some of the barriers we're seeing on a provider perspective to help move this forward in a quick, efficient way. So yeah, thank you for that. And so, with that said, kind of switching gears here, we've learned a lot today about guidance updates. We've talked about stigma. We've talked about barriers to care from a provider and a patient perspective. But Dr. Hubbard, how can we close some of these gaps? What can we do to educate patients about the updated eligibility and lung cancer screening in general? Any thoughts?
Yeah, I mean, as far as from a primary care perspective, I think a lot of it can be in our office, in our exam rooms, because we see these patients, we know these patients. So just kind of walking them through it, what are the new guidelines, who is eligible. I know for me, a lot of times what I do is I will sort of group all my cancer screenings to part of the conversation, when I see these patients for their visits, where we kind of go through what are you due for, what have you completed? And I sort of like to add lung cancer screening into that, because it makes it a little bit easier for them to hear that this is just a normal thing. This is just part of our routine screening. And so I think starting to make it a normal thing to talk about would be really helpful, especially a lot of patients just have primary care providers. So it should be on us to sort of educate them, talk about their eligibility, what we're looking for, some of the things we might find that they might not be expecting to hear, some of the incidental findings, and yeah, just really educate them. They oftentimes trust us, and I think that's a good place to start.
I love that, normalizing it, reducing that stigma we talked about, and integrating it in as a piece of this is a normal, part of our time together here today. And kind of to jump off of that, back to you, Julia, is thinking like, how might data collection in general be used to better assess eligibility for lung cancer screening among Rhode Islanders? Any thoughts there?
Yeah, so this is an area where I think public health, we have a current scenario, and then we kind of have like a dream world, and there's definitely room to grow. So our current scenario is that we're getting some of the information through the behavioral risk factor surveillance system. However, it's not happening necessarily every year for lung cancer screening, and it's not every year that lung cancer screening questions and tobacco use and cessation questions are aligning. So kind of increasing the consistency of how we're asking those questions. An area that I also think there can be growth in, and there is, I think, currently work in progress, is establishing kind of the infrastructure to assess claims data around tobacco cessation and lung cancer screening. So increasing that understanding. And then kind of in our dream world with more funding, there is the National Adult Tobacco Survey, which would help offer like really rich state level data if we were able to fund that in Rhode Island yearly to get a better assessment of kind of who's eligible. And really the numbers, Dr. Healy was talking about that earlier. Right now, we really don't have a good sense of even what the eligible population might be. And then I do think if we could do a little more of that integration of cessation services, more bidirectional. So cessation services who know they have somebody who's a longtime smoker referring back to possible screening points would be wonderful as well. So those are some areas I think for growth.
I love that. I think the bidirectional nature of data, and data is only as important as how we utilize it, how we see it, how we interact with it. So I love that. And I think you mentioned too of like the difference of kind of maybe where we are now in the dream world of where we can go. And I think, seeing the five of you as such incredible panelists here today, I have a pretty big question. So I'm interested in hearing from anybody who may have some insight here, but what would be the best practices, or what would be like the model way of forming a lung cancer screening program? What would that look like? So I don't know, I'll throw it over to Dr. Hilliard first. I don't know if you have any thoughts there.
So I think that's a great question. And it's got to have a balance of, as we've talked about, as Dr. Hubbard, Dr. Nietzsche spoke about very clearly, you've got to have this start with someone who the patient trusts. So it's got to start with somebody in primary care. It can't, unless they, and potentially with a cessation counselor that the patient has built a relationship with, that could also be beneficial, but it's not going to work if you have somebody call. I think we have an opportunity in Rhode Island, like lots of things that we've done. And I think Dr. Healy's comment about the fact that we went from being a blank state to a blue state on that Medicaid coverage map with a phone call. From an impressive person, but a phone call managed to make that happen. There are opportunities to kind of work to more standardize our way of capturing tobacco use histories, and there would be opportunity to consolidate that in one place to start identifying patients and then reaching back out. And I would say in an ideal state, some of that gets centralized. Not that any one person does it, any one imaging place does it, anything else along those lines, but with the idea of public health and centralizing that follow-up, at least for the lung cancer screening of, okay, these patients are eligible. Have they been asked? If they've been asked and they say, no way, I don't want to do it, of course, that's up to the patient. But there would be some ways to leverage the fact that this data can be captured in discrete places. The other thing, you could do it with some little more micro collaboration. So, that would be kind of the big version of a hub and spoke, like Dr. Nietzsche talked about, of put the hub in the center of a state. And yes, we're lucky in the fact that we've got a small state we can kind of get our arms around. But smaller kind of hub and spoke models or smaller kind of models of that with collaborations between primary care groups and radiology groups really kind of exist already, but taking the time to build that out of, okay, we're going to go through our data and either proactively identify patients who probably meet criteria, or retroactively going back and searching through our EHR data to identify patients. And here's how we're going to handle the process of getting them over to radiology, identifying when people need feedback or follow-up, and going from there. So there are opportunities there, but it's going to require conversations between multiple different stakeholders.
I love that. I think you said it really succinctly, and I know we really hope to take some of this information today and help move this forward. And so I think really, coordinated collaboration and conversations, like you said, building trust, and rapport between a provider and a patient, that relationship, and a really kind of balanced model there. So really great opportunities. And I'll throw it over to you, Dr. Nietzsche. Any thoughts about what forming a lung cancer screening program can look like in best practice?
Yeah, I mean, I think I really like what Ross said. I mean, I think Rhode Island has a real opportunity because of its size. And with the formation of the larger academic medical center, you could really see that being a hub of sorts with these various spokes in these primary care practices. Not that the hub has to do everything, but people need to know they have backup for challenging cases or challenging stories. And, the other thing I'll say is the pulmonologist, not that I'm, a little bit of bias here, but I think the pulmonologist is another person that really needs to take an active role in lung cancer screening, because it's not just the identification of the smoking history or the getting the low dose CT, but what do you do with the information? And, it's been shown that as we've changed, as we've refined our ability to look at these nodules in much more nuanced ways, what we don't want to happen is to have a ton of people need unnecessary procedures. And that has those numbers of procedures and the morbidity of some of those has gone down dramatically since we've refined our criteria. So I think it's really important for this to be a very collaborative effort. I would make the comment too that in 2015, the American Thoracic Society and the American the College of Chest Physicians put out a statement paper on how to develop a lung cancer screening program. So there are some papers out there, I'm sure we're not the only ones, that have sort of talked about how you start these programs. But I do think Rhode Island has a very unique opportunity to really at least think about it and think about how we do it in a very rational, very shared way, a very collaborative effort. And like I said, while the VA might be a very different bird, there are lessons to be learned on both sides of this equation. So we're happy to sort of, take part in that.
Oh, thank you. That's really helpful. And I see Dr. Healy, you unmuted there. I'll throw it over to you. Any thoughts?
Yeah, I really appreciate what Dr. Nietzsche had to say about the centralized program. And, the Leahy Clinic is probably the gold standard, how they did the first, they offer lung cancer screening for free, and they've published extensively on this. Having put together 4 different lung cancer screening programs in 4 different healthcare systems, including Rhode Island and Massachusetts, I've seen the barriers to putting these decentralized systems in. And in Rhode Island, we still have the fear. We have multiple healthcare systems, and one system is very fearful of losing patients to the other system. So I think as we tend to merge and collaborate better, this whole lung cancer screening system in Rhode Island may actually be centered in radiology. We are fortunate enough to have, we're about the 15th biggest group in the state. We're not in the VA, unfortunately, but we will also be taking over Kent County and Newport Hospital And we've been able from the radiology side to develop systems. For example, patients who schedule a mammogram with us, I have added a line at the end of the requisition, the lung cancer screening criteria. So maybe patients that come to get their mammo and their DEXA annually will learn. We'll be able to provide them that information. This is the criteria. Do I qualify? We also send letters to all the patients. So trying to take some of the burden off the primary care doctors or the pulmonologists. Every single lung cancer screening study that I overlook, the patient gets a letter and says, your lung cancer screening showed X, your follow-up should be Y. So I think we can develop these systems in the state, but it will take some collaboration with the multiple healthcare systems, which are quite competitive, actually.
No, thank you to each of you for such a thorough answer there. And I think we have some really actionable takeaways. And I think to your point, what a amazing opportunity being here in the small but mighty state of Rhode Island, where we can really, when we talk about integration, we talk about a centralized model, with some, not to say that it's going to be easy, but with some real coordinated conversations, some real collaboration, we have a real opportunity there to move this forward, which is really exciting. So I know we have 15 minutes left of our lung cancer screening roundtable today. So I have one last question I wanted to throw to you, but we have a ton of really wonderful questions from our participants today. So hoping to get through several of those. But my last question, I'm interested in your all perspective, and maybe I'll toss it to Dr. Healy first, because in your presentation, you mentioned the example about policy change with the Medicare fee-for-service coverage for screening, in how as providers having such a great opportunity to help move that forward. And I work in public policy, so I'm really interested in your perspective. Are there anything, what else could policymakers do to support changes that need to happen to increase lung cancer screening rates? Any thoughts?
Yeah, that's great, Dan. You know, the National Lung Cancer Screening Trial was published in 2011 in New England Journal. It took lobbying on multiple levels to be able to get Medicare to actually cover lung cancer screening. It wasn't actually until 2015, don't forget. Now, a year after U.S. Preventative Task Forces gave a B recommendation, that means that third-party payers have 1 year to cover the service. So if we're looking at it, we're about 3 or 4 months in since the current recommendations. The third-party payers are not required to cover the 20 pack years and the 50 to 80 age until 1 year has passed. We're still not getting those patients covered by third party. The issue is we need everybody to understand that the Medicare and Medicaid population, you actually need Congress to change the laws. And that's something that the American College of Radiology, and I'm on that committee, is lobbying Washington. We have a Hill Day every year where every single state, we have at least 5 radiologists visit with every congressman, every senator. And that was our message this past year, was we need to get the law changed. Otherwise, we can talk about screening these patients, but they're not going to come if they're getting a bill for $300, $200, $300. So I think from a policy standpoint, we got 8 months till, the Blue Cross, Blue Shield, neighborhood, they cover it, but we need a national law change in the Congress to get these additional patients covered.
Thank you so much for that. I think that's such a, and we have a lot of folks listening in today. And I think what a great folks from, across our state and beyond, and what a great opportunity for us to use our lived experience, to use your expertise as providers to help move forward and understand and reduce those barriers that we talked about. So thank you. And I look forward to doing what we can at the Lung Association to help make that happen. So I want to transition over. We have some really great questions. So the first one is directed to Dr. Hubbard. Dr. Hubbard, what's your perspective on where PCPs are nationally in terms of knowledge or understanding about lung cancer screening? How much is lung cancer screening a part of the dialogue in a primary care clinical community? Any thoughts on that? Oop, you're muted.
Sorry about that.
No worries.
Well, that's a great question. And I really wish I could speak for all PCPs across, the country. I'm not sure. I'm sure I'm sure there's a variety, to be honest. I know I talk about it with all my patients. I think that's something I definitely put into my yearly visits. Is something I always have. But I really think it's going to come down to how much they know about it, their exposure, and how much they've been trained to incorporate that into their care. I would like to think all PCPs are aware of, the risk of smoking, the screening, and keeping up to date with the criteria. But that's a great question. It would be interesting to see, the variety of practices out there, how PCPs are talking about lung cancer and lung cancer screening.
Yeah, and yep, Dr. Nietzsche.
I just wanted to mention that, it took a lot when we launched our program. One of the biggest efforts we made was educating the primary care docs and kind of walking them through what to expect, what to do, how we could help them, because I think that is by far the largest, it's your largest benefit and your largest stumbling block. You have to have buy-in, and the PCPs have to feel like this is not going to overwhelm them, because it's very easy to make them feel completely overwhelmed. And again, that shared sort of effort and collaboration, but we put a lot of effort into education and communication and kind of going over what our thoughts and what problems might come.
Thank you for that answer for both of you, Dr. Hubbard and Dr. Nietzsche. And part of what you just said, Dr. Nietzsche, really relates back to another question we received, and thinking about that feeling of getting overwhelmed and wanting to reduce a lot of those barriers that you all, so eloquently talked about towards the beginning of our conversation. But we got a question kind of to the patient end of that. So the question says, I have a patient that will cancel and delay their appointments with me because I always ask about smoking and readiness to stop smoking. When they've not been able to do this, they feel badly, and so they end up avoiding all care. How do we give patients the space to fail a few times and trying to quit, but remain engaged in their care? Anybody have any thoughts on that? That's a big question there. Yeah, Julia?
Well, so one piece of that is just is normalizing how difficult and how common it is to have multiple quit attempts, or also to not be ready to quit, given like identifying specific stressors and triggers for that patient. So that's a big piece of that, is normalizing. And then I'm sure this person is already doing that, but trying to utilize the MI technique so that it doesn't feel like an external push from the provider, but more of a team approach. So is this something that you're interested in? And if so, why? Rather than you need to be doing this in order for me to see you as a compliant patient. And there are some MI trainings. I know actually ALA has a 1-hour free training for providers on doing the ask, advise, and refer model with some like sample scenarios and things like that. So that's just one resource that I would mention, but it's difficult. And there's not, I'll defer to the providers, but I know there's not enough time in office to really do what you might want to do for a slow, full MI, supportive intervention. And so that's a challenge.
Sure. Yeah, I would just add, as a PCP, we definitely have patients like that. I've had patients come in and say, can we please skip the counseling this time? It's been a really rough month. So I think just making sure it's a two-way conversation, just really listening to them. Sometimes they really aren't ready to talk about it. And that's okay. Say, obviously we want to talk about this in the future, but we'll skip it this time, and reach out if you want any help or any resources before I see you next time.
I also think it's important not for patients to believe that they can't be screened if they're not willing to try a quit attempt. While I think we want to link those, I don't think that can be. And patients, they're funny, right? They'll take a message that you never intended to give. I think you have to be very careful not to link it in such a way that you're excluding them from screening because they tell you, I just can't quit. I just won't quit. And I think you have to allow that to happen and just remember to revisit it, at each part of the process.
Sure. Yeah, patients are coming in at all different points of readiness. And but yeah, I see you're unmuted, Dr. Healy.
Yeah, I think from the lung cancer screening, the CT part of it, I worked with the Department of Health, the Department of Public Health at Brown University. We created questionnaires for our screened patients. One questionnaire geared towards the former smokers and a specific questionnaire geared towards the current smokers. And there are some very validated questions, including a ladder where the patient sort of circles where on the ladder they're ready for change. And we found some pretty interesting results, which will shortly be published, but we did this to about 2,000 patients in the last 2 years. And it turns out that about 90% of the current smokers at the time of their CT lung cancer screen are ready for smoking cessation. So I think these types of results will come out nationally. And I think the patients who are actively engaged with the CT lung cancer screening, this is a great opportunity to team up with smoking cessation specialists and pair up the patients who actually admit on paper, which is often easier than face-to-face, that they're ready for that process to begin. So I think in the near future, you will see the CT patients that come for CT actively engaging our smoking cessation colleagues. And I hope in Rhode Island, that's something that we can actually start doing as soon as possible, because these patients are looking for help.
You got a thumbs up from Julia there. So that's exciting. Yeah, looking forward to hearing more about that and seeing that put into practice. So I know we only have a few minutes. So I think we can get to one last question before I'll close us out for the afternoon here. So kind of switching gears, we had another great question. They wanted to talk about or address non-smoker screening. And really the question is, what are your methods? How are you capturing the person who has annual screenings yet identified as stage 4, especially 40 years and younger? Talked about kind of genetics as well. So any thoughts there on screening of people who don't smoke? Someone want to take that question? Yeah, Dr. Healy.
I get this all the time. We have patients calling the office saying, I have a family history. I'd really like to get the CT scan, but my doctor tells me I can't get it. Can I just buy the scan? Can I come in and pay? We actually have patients that call frequently. And on the national level, this is something that's often discussed. I think the biomarker research is really important here. We need saliva or blood testing. And there are many centers who are doing lung cancer screening and lung cancer centers of excellence who are collecting blood and sputum on all lung cancer patients, regardless of smoking history. And that's probably going to be the future of screening for lung cancer in patients who do not have meet the criteria for CT in smoking. So it's really the biomarkers.
Thank you for that answer. And Dr. Nietzsche?
Yeah, I mean, I think it's really important to say that there is no screening for non-smokers. That's not a proper term. I mean, we defer to primary care because primary care sometimes will want to get a CT for a patient that does not fit, and that's, we never would say that's not okay. What we have to say, it's not part of the lung cancer screening program. So they're distinguishable. There's clinical care and there's screening programs. A screening program has very specific eligibility, and it doesn't include vaping, and it doesn't include chewing tobacco. I mean, it's not that these things aren't important, but at this present time, the science is not there to suggest that those are within a lung cancer screening program. So I think that's a distinguishing thing. It's not clinical judgment. It's really programmatic decisions.
No, thank you for that answer. And I think that kind of really sums up a lot of what we've talked about. There's a lot more opportunities, a lot more to learn, a lot more for us to strategize around and implement. From some of the things needed from a congressional standpoint, from policy change, to additional science, to the ways that we can continue to work together, to collaborate, to continue to have intentional conversations about how we can move this forward. So I know we have just another minute or so left. There are lots of other great questions here, and we will most certainly do some follow-up, making sure that we continue to get those answered. But I did want to say thank you. Events like these really provide important opportunities for us to examine the healthcare system and the ways that it serves our population. Our ability to bring together so many experts we've had here today from such different disciplines and backgrounds, I think has really helped reveal the breadth of expertise and opportunity for change. And that can really give us hope. And, as stakeholders, we can all learn through the shared experiences and prioritize improvements that are not only evidence-based, but also informed by practice. So our organizers of today's roundtable will be working to analyze today's many rich, robust discussions to identify opportunities to implement policy, systems, and practice changes in hopes of helping us support our healthcare providers here in Rhode Island and beyond to identify and screen more patients who are living with high risk for lung cancer. And I think, as you heard from our 5 panelists, by really working together on these efforts, we can decrease late-stage diagnoses and improve outcomes for survivors. So at a later date, these newly identified opportunities will be shared with everyone here today so that we can continue this important work, continue these conversations, and really work to creating some positive, lasting change. So I did just want to say thank you to the many people who shared in this important work today. I wanted to say thank you to the U.S. Centers for Disease Control and Prevention, or the CDC, for making today's roundtable discussion possible. And thank you to all 5 of our incredible panelists, or 2 presenters, for participating and sharing your expertise and ideas as well. And I want to say a special thank you to our planning committee, who worked really closely with the Comprehensive Cancer Control Program at the Rhode Island Department of Health to really conceptualize and coordinate the many, many moving parts for this event. And finally, a huge thank you to Maria Sullivan and Jennifer Maloney at the Brown University Office of Continuing Medical Education for their experience in producing this event and keeping us all on track every step of the way. With that said, thank you again to our panelists, our presenters, our organizers, and to all of you as our participants who tuned in for this roundtable event. Thank you.